School, I got destroyed with the retinal exam because the attending that I had, he really wanted us like a good internist skill is to look at the fundoscopic exam. So, but for the purpose of your boards, at least I want you to memorize the abnormalities. So there's a classification called the Keith-Wagner-Barker classification. Rami's gonna give you the presentation, so you guys don't have to worry about like the slides. But we have like grade 1 to grade 4. So the grade 1 is just mild narrowing of the arterioles. In grade 2, you see like moderate narrowing with AV arteriovenous nicking. I'm going to show you, and these are usually changes associated with long-standing hypertension. You're not going to see the arteriovenous nicking in the acute setting. So this is a normal fundoscopic exam, and here you see the narrowing, the copper wire narrowing of the artery, and in this one, actually you can see the nicking, AV nicking. So you just have to spend some time looking at it, and when you see the grade 3 or grade 4, you actually think about like these are serious. And I want you guys to get familiar with the hemorrhage, with the cotton wool spots, and the presence of any exudates. And the important thing is that grade 3 and grade 4 are highly correlated with progression to end organ damage and decreased survival. So if they show you pictures with papilledema or any of these exudates, I have a picture here. You can see actually a bunch of like abnormalities here with some hemorrhages and the cotton wool changes. And I have a picture of a papilledema here. You cannot see the borders of the optic nerve. You can see the flame hemorrhage. You can see the heart exudates here and the cotton wool spot. This correlates with bad prognosis for that patient because it's very clear that this person has severe hypertensive end organ damage, and not only in the eyes, everywhere else. For nephrologists, it's very useful to look at the eye exam because it's a window to the kidneys. So when I look at the eye exam in a diabetic and I see diabetic retinopathy changes, proliferative, non-proliferative, primarily proliferative, I pretty much can very comfortably call it diabetic renal disease, and I don't need to pursue a biopsy unless the patient is having like an accelerated loss of renal function or they have an active urine sediment. Those patients definitely I think about doing a renal biopsy, but like common things are common. I look at it, the patient has documented diabetic retinopathy, proliferative diabetic retinopathy with 10, 15 years of diabetes poorly controlled. I can very comfortably call it diabetic renal disease, and I don't need to do a biopsy. So for us nephrologists, the eyes are a good window to the kidneys. Okay, so laboratory testing, everybody gets an EKG, look for LVH. You're gonna look at Dr. Ben-Zur is probably gonna review with you guys the signs of LVH and EKG. You look for signs of ischemia, T-wave inversions, ST depressions, ST elevations. You look for all infarcts or any abnormalities that you can tell. Renal function, you test the urine. I always teach students that the urinalysis is the EKG of a nephrologist. So I'm pretty sure you're never gonna go to Dr. Ben-Zur without an EKG. Please don't go to your nephrology attendings without a UA, because the urine, that's where the money is for the kidney specialist. But you look at other things like BUN creatinine. How do you guys think the urine looks on a hypertensive nephrosclerosis patient? What do you expect to see in the urine of these patients? A lot of protein or a little bit of protein? And how much is low protein for you guys? Give me a number.
Less than 3.5 grams.
That's subnephrotic, but it's also less than that. Most patients, they have a blind urine sediment, meaning that I don't see any red blood cells or any white blood cells or any casts. You can have a little bit of proteinuria, and by little bit I mean anywhere from microalbuminuria up to 1 gram. Can you have 1.5 grams and still be hypertensive nephrosclerosis? Absolutely, yes. But statistically speaking, it's more likely that you have like proteinuria and the less than 1 gram in a 24-hour urine collection range. but it's typically the UA typically looks normal unless you're having a hypertensive emergency, and you can see microscopic hematuria or like even gross hematuria in some patients. You do a CBC, and again, the CBC, you look for things like thrombocytopenia, you look for things like anemia, and then you suspect like acute hemolytic anemia. Maybe this is HUS or TTP. Maybe I'm going to look for schistocytes in the peripheral smear. So if they give you schistocytes on your boards, that's very abnormal. That's micro, that's MAHA, microangiopathic hemolytic anemia, or TTP. So make sure you guys, know what they're asking you. And you do a chest X-ray just to look for signs of aortic dissection, like widening of the mediastinum. You can look for acute pulmonary edema. I want to say something about pulmonary edema in the setting of hypertension. So there is an entity called flash pulmonary edema that can originate from cardiogenic origin, maybe like an acute valvular dysfunction because the patient has some sort of like obstructive coronary lesion. But we also see flash pulmonary edema in those patients suffering from bilateral renal artery stenosis. You rarely see it in unilateral renal artery stenosis because the other kidney compensates. The other kidney increases the natriuretic. In other words, they increase the sodium excretion to try to compensate. But if you have bilateral renal artery stenosis, you really don't have a backup mechanism. So these patients can go from being fine to develop flash pulmonary edema. So if you have a case, an interesting case that we can't figure out why this person is going into flash pulmonary edema, think about bilateral renal artery stenosis. Okay?
What's flash pulmonary edema?
Like you're fine now, and in a few hours you can develop sudden onset. Like these patients develop like very sudden onset pulmonary edema, recurrent pulmonary edema, and from an unclear etiology. Okay, so you look at the aortic arch, your cardiac enlargement, displaced PMI, all those things that are classic internal medicine teaching points. So aortic dissection, you think about severe tearing chest pain, unequal pulses, widening mediastinum. You do a contra-CT scan or an MRI, but if you have good clinical suspicion, you can do the clinical diagnosis. If you have a patient with pulmonary edema, CHF, you do a transthoracic echocardiogram, and you differentiate between systolic dysfunction versus diastolic dysfunction versus a patient with severe MR. Systolic dysfunction, you guys know, is the depressed ejection fraction, versus diastolic dysfunction is patients with stiff heart. It's like the inability to achieve normal relaxation in diastole. So these patients they're prone to develop, and this is actually one of the classic hallmarks of hypertensive heart disease is diastolic dysfunction. They still have a preserved ejection fraction, but they're unable to relax. And that's the reason why one of the goals is to give them medicines that will help with, increasing the diastolic feeling. Dr. Ben-Zur will teach you about those medicines in the future. The management, you think about elevated blood pressure without end organ damage. We call that hypertensive urgency, and that can be managed in the clinic with oral medications, and you can send the patients home after a few hours of observation. If you have, and remember, those patients, we do a gradual reduction of blood pressure, and you almost never try to normalize them right away because there's no evidence showing that these patients, they benefit from such an approach. And number two, if you're very aggressive. The other day I saw a patient, she got admitted to the hospital. She went to the clinic, she had severe hypertension. The doctor that saw her gave her, which to me was excessive, gave her like 3 doses of clonidine within an hour and gave her a calcium channel blocker before she let her go. She ended up in the hospital with profound hypotension. So the key point is if the patient has no symptoms and it's just hypertensive urgency, you're taking some action, you're starting a medicine, probably a healthy dose of Norvas, you give them 5 milligrams, you let them go home, you give them a little bit of clonidine to be used as needed, not to be used daily, and you send the patients for outpatient referral. But aggressive correction is not necessary, and there's no evidence showing that it's actually the right thing to do. So, and then we have the other patients that are having elevated blood pressure with target organ damage. Those patients, we define them as hypertensive emergency. You have to use parenteral medications, and The goal is to reduce diastolic blood pressure by 10 to 15%. And this is actually a recommendation that may vary depending on the syndrome. I'm gonna actually detail all of them, so you know more or less what I'm talking about. But most patients we try to normalize. We try to reduce it by 25% in the first 24 hours. Most patients, with some exceptions that I'm gonna cover. So there is something called a cerebral flow autoregulation. So this is one of the reasons why we try to aim, when you guys are titrating pressors, when you guys are in the ICU, like a patient got admitted with distributed shock from sepsis, then you always write orders like, oh, we're going to try to target a map of 60 or 65. We know that the minimum of medium arterial pressure is 60 to be able to guarantee an adequate perfusion to the brain. Sometimes you're not able to achieve that, and that's when patients become altered in the ICU. But in chronically hypertensive patients, this autoregulatory range is higher, and that's the reason why we don't bring down blood pressure very quickly, because it can cause more harm than good. So typically the medium arterial pressure in chronic hypertension, the autoregulation is anywhere from 100 to 120. So again, 20% in the first hour, the reduction in the MAP, and should always be done with close clinical observation. The management, this is ICU, no question about it. If a senior resident is trying to block the patient from admitting to ICU, you may want to have a very professional discussion about the evidence, because these patients, they may need to be on a drip, and in the floor, the nurses, the ratio, patient to nurse ratio is much higher. It's usually 4 patients per nurse, whereas in the ICU is 1, maximum 2 patients. So it's not safe to manage these patients in the floor. So you can always have a professional discussion with the residents. This is something that you guys are going to experience when you're in training, people trying to block because they don't want to admit another patient, but the right thing to do is to admit these patients to the ICU. And which parental medications, it depends on the situation. I listed, basically, if you help me with the next question, please. What's your name again?
Erica.
Erica, can you help me with this question?
Which of the following drugs should not be used to treat hypertensive emergency? Sulfonylurea, nifedipine, labetalol, acyclovir, nicarpidine, or 1 and 3.
Which one? 1 and 3, yeah. I mean, for the most part, unless you're dealing with a scleroderma renal crisis, or unless the patient they need to be afterload reduced with captor pill titration. That's quite common practice in the coronary care units when the patients they need the afterload reduction. But if they're in acute CHF, but primarily we stay away from sublingual nifedipine. So if you have a preeclamptic patient, you never give them nifedipine. Nifedipine is safe in pregnancy, but it's never safe in the setting of an acute crisis of preeclampsia, because it's a long-acting agent and it can induce profound hypotension. So, like a lot of studies show that you never use nifedipine in hypertensive emergencies. But labetalol is very commonly used. There's an IV form, usually 10-20 milligrams IV. And nicardipine is very used, especially in the setting of a ischemic or hemorrhagic stroke. So we also, from the beta blockers, we have the labetalol and the esmolol that you can use. From the calcium entry blockers, we have nicardipine. That's the only one that's actually available IV. And I've never used phenoldipan, but it's listed as it's a dopamine 1 receptor agonist. I'm sorry, it's a dopamine 1 receptor agonist. I have never used it, but it's described as one of the medications that you can use in hypertensive emergency. And we have the vasodilators. I'm going to go over the nitroprusside later, have a couple of slides. And we have the nitroglycerin. I misspelled nitroglycerin. So this case that you read at the beginning, he presented with an acute ischemic stroke or cerebrovascular bleed because there was a shift. So he had a bleed. So probably the agents of choice are labetalol or nicardipine. very often we combine them. But if you have a patient having severe blood pressure after ischemic stroke, it's generally accepted that we let the patients be hypertensive for some time. We call that permissive hypertension. I don't know if you guys ever heard of that concept, permissive hypertension. We want to hold on aggressive lowering unless you're actually thinking about giving TPA, like thrombolytics. Have you guys ever seen an acute stroke? Have you ever been in a hospital, like the patient being like a code stroke? So it's very dramatic because time is brain tissue. It's like when Dr. Ben-Zur gets called with an acute MI. He probably will take you to one of his cases like he did with me. Time is precious. So everybody needs to move fast to help these patients. And part of the things that they do is that if the patient presented within 4 hours, they're considered candidates for thrombolytics if they're not having a hemorrhagic stroke, or if they're not severely hypertensive. So if a patient is severely, excessively hypertensive, let's say systolic greater than 220, those patients you need to bring down a little bit. So that's why I'm listing here. If you're considering thrombolytic therapy, you need to bring them down a little bit. But if you're not considering thrombolytics, you can let them run. Let's say they presented with 180, and you can leave them alone. But if you're gonna give them thrombolytics, you need to aim for something like 185, 180s. That's basically what most neurologists they want to have. And the decision about giving thrombolytics is made by the neurologist, but they usually do this decision over the phone. They rarely come in. And is the internal medicine doctor or the hospitalist consenting the patient or the family and making sure there's no contraindication, documenting neurological exam very, very carefully. So it's not, if you're on call and if you get an acute cold stroke, it's not fun. You're gonna be very busy for the next 1 or 2 hours, trying to get a CT, trying to get a hold of the family, doing consents, talking to neurology. Anyway, it's a very busy situation for the admitting resident. So this slide I got from UpToDate. So it's basically the approach of a patient that is eligible for, that is eligible for acute reperfusion therapy or TPA. So you give them labetalol, usually anywhere from 10 or 20 milligrams, and you reassess. And you can give them nicardipine, and nicardipine is actually, there's a lot of data showing that it lowers the stroke edema. After stroke there's a lot of inflammation and edema, so that's why it's one of the recommended medications. But the management to maintain a blood pressure at lower or below 180/105 after an acute reperfusion therapy. But if you're not considering the patients to be eligible for TPA, it's okay to leave them with the permissive hypertension during the first 24 hours, and then you start correcting, you start correcting them the following day. Okay, so cardiac conditions associated with hypertensive emergency, you can have acute pulmonary edema with systolic dysfunction. These are the medicines that we normally use. Loop diuretics, obviously we're trying to get rid of the fluid. If the patient is dialysis dependent, we need to dialyze them. We need to try to remove the excess fluid, because most dialysis patients, they have very poor urine output, or they're completely anuric. And most patients, when you interview a dialysis patient, you need to ask them, do you still urinate? And if they make urine, you can give loop diuretics, but most of the times you need to dialyze them because it's not going to be enough urine production. But these are typically the medicines that we use when we're confronted with a cardiac condition. If you have diastolic dysfunction, we use IV beta blockers. Verapamil, like I said, to allow the patients to improve the diastolic filling. And you can do nitroglycerin or a loop diuretic, and I'm not saying or, and loop diuretics to get rid of the excess volume. If you have acute myocardial ischemia, these patients, they get treated with an IV beta blocker and nitro. You can put them on a nitro drip to increase coronary vasodilatation. And if a patient comes in with a sympathetic crisis, and you may get asked this question, if somebody has like a pheochromocytoma, or somebody like patients that are using a lot of cocaine. So make sure you inquire about cocaine, because the last thing you want to do is to just manage them with a beta blocker, because that would cause unopposed alpha stimulation, and they can become more hypertensive. So this is a board question in internal medicine boards. I don't remember getting it on the student boards, but always remember about inquiring about recreational drug use or illegal drug use. And for those patients that you actually that are presenting with a sympathetic crisis, you want to avoid just the beta blocker. Okay, always remember that. So no labetalol. If you manage these patients usually with phentolamine, that's the correct answer for your boards. If it's a pheochromocytoma, or if it's a guy with hypertensive crisis related to cocaine. Okay, so yeah, this is what I just said. Cocaine use, beta blockers can increase blood pressure, worsen coronary artery vasoconstriction, and decrease survival. So the teaching point is avoid beta blockers, including non-selective agents such as labetalol in a sympathetic crisis. Okay. So this is recommended. If it's phentolamine. If it's the other stuff, you use nicardipine, phenoldiazepam, verapamil, or benzos. Benzos are very effective for those patients that present like with a lot of agitation. Okay, aortic dissection. So 70% of the patients with ascending aortic dissection die within 2 weeks. So this is something, if you miss this is really bad. When I was at R2, the ER was really, really busy. They called me with a patient that was waiting like for 20 hours. He was only 35, and his blood pressure was incredibly high. And he presented with severe hypertension, acute kidney injury, and they were waiting for a step-down bed to admit the patient. You guys know that step-down is like one level below the ICU. And the ER resident called me like, hey, this patient needs to be admitted, come and see him. I went downstairs, and the guy, I've never felt this way. I was driving in the 405, I had to pull over, call 911. I have never felt this. The guy was pretty healthy. I mean, he thought he was healthy. And his blood pressure was super high. The guy's creatinine was 3, and he got labs like a couple of years prior, and he was normal. And the guy basically, all the story was consistent with dissection. The guy had back pain. I told the resident like, oh, I'm very uncomfortable admitting this patient to a step down. This person needs to go to ICU. I think he needs to be rolled out. The guy was already 22 hours in the ER. So by the time they called a cardiology consult, the cardiology fellow did an echo. The guy had like a massive dissection. I mean, he was so bad that he had to be transferred to cardiothoracic surgery at UCLA, and he ultimately ended up dying. He dissected all the way to his renal arteries. It was a really bad, really, really bad case of dissection. So my teaching point to you guys is, whenever they admit a patient, you're gonna get so tired of admitting chest pain, because everybody has chest pain. You only need one case that you miss to get in trouble. And when you get a chest pain, always examine the patient, always, and uncover the chest. I'm gonna share another teaching point. Like the other day, the ER resident called me, hey, we need to admit this patient to rule out acute coronary syndrome. And I went in and I examined the patient's chest. It was a lady, like 70-year-old lady. The lady had horrible shingles. Like, no wonder she had chest pain. She didn't need to be admitted, but I went to the ER resident and told her, did you examine the patient? Like, yeah, I examined the patient. Like, you look at the chest. And the resident went with me, and I showed her, like, look at all these blisters. Oh, yeah, but she still needs to be admitted for rule out, like, whatever, It was very clear that patient didn't need to be admitted. So examine your patient. Always examine the skin. Every time you have a patient with back pain, musculoskeletal pain, chest pain, look at the skin, lift the breast, look for shingles. You see these a lot, especially in the elderly patients. I had shingles when I was in medical school. I was probably under a lot of stress, and I developed an outbreak of shingles. So shingles can happen to anyone. So always examine the patients. But the good news is that if you catch it, patients have very good chances of having good survival. You don't want to miss that. This is my teaching point. So, and the management of aortic dissection for your boards is very different, because you rapidly lower the systolic blood pressure to a target of 100 to 120. And you use that with IV beta blockers. You don't just do a vasodilator alone in the setting of aortic dissection, because if you just do a vasodilator, it can cause reflex tachycardia, it can increase cardiac ejection velocity, and it can extend the dissection. That's the bottom line. So for your board, always the right answer is IV beta blockers. You can use the vasodilator in conjunction only after you have given the aortic dissection patients IV beta blockers. But this is one of the few exceptions where you want to normalize or rapidly normalize the systolic blood pressure to 100 to 120. Okay. So standard therapy, like I said, beta adrenergic blocker plus a vasodilator. Usually esmolol is what I use. And plus or less you can give any of the vasodilators. And nitroprusside, it can be used as well. I don't know if you guys ever use nitroprusside. I have a couple of slides at the end. Two things that I want to say about nitroprusside. So this is the European Society of Cardiology guidelines. I got this slide from UpToDate. And these are the recommendations when you suspect, dissection. You get a detailed medical history. Detailed medical history. You get a line. You send everything: CK, troponin, myoglobin, D-dimer, hematocrit, LDH, EKG for documentation of ischemia, heart rate and blood pressure monitoring, pain relief. This is very painful. If the patients are conscious, this is extremely painful. And you reduction of systolic blood pressure, and you transfer them to ICU. If the patients are severely hypertensive, you add sodium nitroprusside, and you titrate it for a systolic blood pressure goal of 100 to 120. So these are the classification. I think it's beyond the scope of the talk, but this is the classification of like the evidence behind this recommendation. So if you can tell, like the first is class 1, so it's very strong evidence doing this recommendation. Okay, so if you have a patient, you're gonna get called as an internist on call. You're gonna get called a lot about acute postoperative hypertension. Usually managed by the anesthesiologist, but after hours they usually call you. So either this is increased release of catecholamines, but there's different mechanistic ways. This patient may have like a bladder distension, they may have severe pain, they may have like severe release of acute stress hormones. These patients is basically one of the key things that you do is that you give some of the antihypertensives pre-op, but most surgeons are going to disagree with this approach because they wanna prevent hypotension in the OR. But typically, when you are advising patients to prepare for surgery, you always tell them you take your pills with a little bit of water. One of the few things that you tell them to hold is any type of insulin, or you even, and if the patients are on metformin, usually we stop metformin in the hospital setting because it can cause lactic acidosis if you need to give them contrast or if you need to, if they develop acute kidney injury. So metformin is common practice that we stop, but most of the times we just give the blood pressure medicines before. So you just resume oral medications, and if they're having like pain or anxiety, you can use benzos or you can use narcotics to control the pain, and that's usually very effective. And that's another thing that I try to teach students. If your patient is in severe pain, just control the pain. Don't keep escalating the antihypertensives unless they're having a hypertensive emergency. But it's common for the residents and attendants to have this tendency to like, okay, Norvas 5, okay, let's give him nifedipine 90 then. Don't do that, because when this patient go home, what you're gonna cause is a lot of harm. This patient is gonna pass out with severe hypotension if you're very aggressive with your goals. Okay, about sodium nitroprusside, it's recommended you can use it for all hypertensive emergencies except for eclampsia, and you can use it in aortic dissection, like I showed you the European guideline recommendation. You can use it for acute pulmonary edema with systolic dysfunction. It's very effective. One of the disadvantages is that the pharmacy needs to prepare it, and usually it comes in it's covered by a bag because UV light can actually deactivate. I don't know exactly what the effect is, but the pharmacy is very labor intensive to get a pharmacist to prepare it for you, so you may lose some valuable time. If you have some nitro that is already ready to go, the nurse can put it within minutes. And the other disadvantage is that it can actually, neurosurgeons don't use it because it can increase intracranial pressure, and that's a disadvantage. especially if you're dealing with a patient with trauma or severe abdominal compartment syndrome. Those patients already have like a lot of intracranial pressure elevation. And another disadvantage is that it can actually reduce the regional blood flow to the coronary arteries. And if you use it for more than 24 and 48 hours, your risk of cyanide toxicity can actually increase. So it's a quick fix. You use it for a couple of days, and then, most of the doctors, they tend to stop it. But if you keep it for over a week, your risk of cyanide toxicity can exponentially grow. The other thing is that you don't want to give them in the setting of hepatic or renal dysfunction, because the risk of toxicity is much higher in those two settings. Okay, so like I told you at the very beginning of the talk, have we made any progress? Yeah, like the statistics show that this was a pretty lethal disease. Like back in the 30s, when we didn't have enough available therapies, if you had grade 4 retinopathy, pretty much you were dead within a year. Whereas now, it all depends on how, not only the development of antihypertensive medications, but it also depends on your clinical skills to be able to diagnose it, to treat it, to be able to recognize secondary hypertension causes, and to be able to have an appropriate disposition of these patients. If you let them go and they don't have any, a lot of social support or a lot of follow-up, they're gonna come back, and next time it may be fatal. So this is a summary of the recommendations. Basically, the take-home message is that most patients with significantly elevated blood pressure, they don't have any acute end organ damage. Again, common things being common, hypertensive urgencies are much more common than hypertensive emergencies. But your job is to always identify or rule out and to document that you did an exam, including a fundoscopic exam. You describe all the symptoms that I mentioned, arising chest pain, shortness of breath, headaches, focal weakness, blah, 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 blah. You need to be very careful with your documentation, because this is the way it is. This is a tough business. You're going to get sued no matter what. Make sure you do your part. And the other teaching point is that you evaluate for secondary hypertension in all patients presenting with a hypertensive emergency. And another thing that you want to, after you start managing with IVs, if things are stable, you want to start introducing some of the oral agents about 8 to 24 hours after the admission, and you gradually stop the IV. One of the nice things about nitro is that you can titrate it very quickly, and you can actually go up and go down depending on what's going on, and it's very easy to stop it in the ICU setting. But your goal is to try to give them back the home blood pressure medicines after you get a good history. And you tell them, hey, listen, I don't want to over-medicate you. This is the way you sell it to the patient. So I want to know what's happening. Were you taking your meds? Because if they were taking the meds, there's really no reason to just put all the medications and give them new medications, because you're going to cause more harm than good. So that's when your good clinician aspect is very important. That were you taking your medicines? Were you being good with your sodium? If you have kidney disease, again, take this concept home. It's very important that you understand. If you had kidney disease and you were eating Chinese food, Asian food, like soy sauce, fish sauce, if you were adding extra salt, you were eating McDonald's every day, you're going to develop a hypertensive emergency. So very simple, you need to get rid of all those things. And how do you accomplish that? By preparing your own meals. That's the only way. If you ask your patient, how many times do you eat out? And the patient says, every day. Forget about it. It's impossible that this person is adhering to a sort of restricted diet. Okay, so in the optimal therapy, the choice, remember, the agent of choice depends on what kind of presentation, clinical syndrome. The blood pressure goal varies according to a specific hypertensive emergency. I already told you that if the patients present with acute aortic dissection, it's very important that you normalize them. If they present with an acute ischemic stroke, it's okay to leave them with permissive hypertension. If the patient presented with an acute intracranial hemorrhage, those patients, they need to be normalized as well. So the goal depend on the clinical syndrome that you're confronted. So for your boards, you're very likely to get questions on hypertension and aortic dissection. You already know two things, and you're never going to get wrong these questions. Two things: IV beta blockers and normalization of systolic blood pressure to 100 to 120. Okay? And So, and for most patients, we want to do a gradual reduction, allowing like 20% reduction in the MAP in the first hour and about 25 in the next 20 in the other 23 hours. In the first day, 25. Okay. So those are the teaching points. Have any questions?
So in a patient with intracardial problem, when do you start normalizing the blood pressure? One day after?